V-Gel Advanced and airway management. What is the purpose of airway management? Before we look at the different devices available, we need to revisit airway management and look at what we're hoping to achieve. By using an airway device, we are hoping to gain and maintain a patent airway. This will in turn allow us to safely deliver oxygen and anaesthetic gases, whilst at the same time providing us with a patent airway for intermittent positive pressure ventilation, also known as IPPV. At the same time, we also need to protect the airway with a fluid seal. This will protect against reflux or regurgitation from the patient, and also any fluids we are introducing as a result of a procedure, for example, dentals. Finally, we also need to have a gas seal to protect the environment from any excess volatile agents that are exhaled. Without a gas seal, these drugs will leak into the atmosphere and are inhaled by staff members, so of course this needs to be avoided. Now you've decided that airway protection is needed, you then need to decide where on the patient you're going to provide this. At the front by the mouth and nose, in the pharynx area, or in the trachea. There are different devices available for you to choose from, and each have their pros and cons. Face mask. These devices are manufactured by several different companies, but they all look roughly the same as the ones shown in the picture. The face masks are simply placed over the patient's mouth and nose, and they breathe in the natural way. Face masks do not provide a sealed airway. They do not have a fluid seal, nor do they have a gas seal. This makes them unsuitable for providing IPPV, as you cannot get positive pressure and force air into the lungs. They are not suitable for volatile gases, as there is no gas seal to prevent environmental contamination. Equally, you cannot control the amount of anaesthetic the patient is receiving, as too much agent is allowed to leak into the environment. And as there is no fluid seal, they will not protect the patient's airway against any fluids. They are suitable for the delivery of oxygen in the uncompromised patient, for example, when you are pre-oxygenating your patient prior to anaesthesia, or upon recovery when an alternative airway device has been removed. They are also very easy to use. You simply need to place the patient's mouth and nose into the device. The endotracheal tube, or ET tube. This device was invented in 1778 and has been in regular use since 1878 until recent times. There have been some minor changes since its inception, but for all its intents and purposes, the device has remained the same. When you consider the number of changes that have happened in the same period of time in terms of anaesthesia protocols, drugs and monitoring, it is quite astonishing that airway management has not been addressed and updated as well. There are several issues with the ET tube. The first is that it's manufactured for a human's anatomy and is therefore not suitably shaped for our patients. The hard material that they are made from almost guarantees that damage will be done immediately upon insertion into the trachea. The device will strip away the delicate cilia away from the lining of the trachea, causing trauma and exposing the patient to infection. They will not be the correct size, as the ET tube must first pass through the narrow larynx in order to reach the wider trachea. This will cause airflow restriction to the patient, in addition to the simple fact a tube is sitting inside another tube. The ET tube should not be inserted further than the thoracic inlet. This ensures that should the cuff be inflated, it is done so in the correct place. If placed correctly, there will be a large amount of tubing, dead space, leaving the patient's mouth. So each ET tube should be cut to the size for your patient. Unfortunately, this is often not done, and instead the ET tube is pushed further into the trachea, so that the end of the device sits by the patient's incisors. This of course means that because the device is pushed further into the trachea, more trauma has occurred, and if the cuff should then be inflated, the cuff itself can cause a tracheal tear or rupture. Once used, there is no protocol for cleaning ET tubes, as most devices are suitable for single use or minimal use only. They are then often stored on racks in the practice, such as the one shown in the picture, meaning that they are exposed to contaminants, which the next patient will be inhaling. You can visualise insertion during placement of the ET tube, and this is considered as a pro for this device. What is a V-gel? A V-gel is an example of a supraglottic airway device. These are species-specific medical devices that are designed to obtain and maintain a patent airway without touching the anatomical airway structures. The human eye gel first appeared in 1986 and with a few minor changes has been used ever since. These devices are used in hospitals around the world, and all first responders such as paramedics, air ambulances are likely to have an eye gel on board. The first animal-specific devices were introduced in 2012, with the V-gel for rabbits and cats being available for the veterinary market. These devices have recently been slightly redesigned and in 2020 were relaunched as the V-gel Advanced. When the V-gel first arrives, it will have a small yellow plastic insert to maintain the shape of the bowl during transport. This has to be removed prior to use and will no longer be required. This slide shows the V-gel Advanced for rabbits and cats with the various different parts numbered, which we will look at in turn. Number 1. The low dead space connector. A connector used to connect the V-gel either directly to your circuit or your capnograph. The dead space within the connector has been reduced for those smaller patients. Here is a closer image to show you the low dead space connector. Number 2. The ridges for tying the tie. You would use these ridges to aid you when you are securing your tie to the V-gel, as they prevent the tie from slipping. You will notice that on the rabbit V-gel, these ridges are broken to prevent them from catching the rabbit's incisors upon insertion. You would then secure the ends of the tie to your patient in much the same way as you would an ET tube. Number 3. The shoulders. The shoulders will be stopped at the paraglottal arch and will therefore prevent the V-gel from being over-inserted. Those of you that are familiar with the original V-gel will note that the bulk has been removed, making the shoulders a lot slimmer to aid visualization of the mouth, especially during dentals. Number 4. The bowl or skirt. The bowl or skirt of material surrounds the airway channel of the V-gel. This flexible skirt, once placed into position, will surround or envelope the anatomical airway structures to provide a high-pressure seal. This provides a sealed patent airway, but without touching any anatomical airway structures. A closer view of the ventral surface of the V-gel with the bowl or skirt over the airway opening of the device. Number 5. The esophageal plug. This area sits just inside the upper esophagus and helps to prevent any stomach contents from being able to reach the airway. In this slide, you will see a diagram of a cross-section of a cat's skull with the anatomical parts labelled. In this slide, we have mimicked the placement of the V-gel Advanced so you can see how the device is placed and where it sits to provide a patent airway. Why use a V-gel? The devices are species-specific, so it therefore mirrors the patient's anatomy. No increase in airway resistance as the patient breathes completely naturally with no obstructions. No tracheal ciliary trauma or laryngeal trauma, as these structures are not touched during insertion or placement. They are quick and easy to place, so that an airway can be established quickly and effectively. Anyone can place a V-gel with minimal training. The patient's anatomy and the device does all the work for you. The user is simply providing the momentum to push it into place. Increase comfort for your patient with a much smoother recovery. The bowl or skirt envelopes the whole larynx and creates a high-pressure seal. Each size of V-gel Advanced will suit a greater range of patients. More buccal space and security for dentals. Low dead space connector. The epiglottis sits inside the bowl, so issues relating to those rabbits with an enlarged epiglottis are greatly reduced, as has the incidence of blue tongue in rabbits. Blue tongue is caused by pressure of the device on the lingual vein and we have discussed this further in the presentation. The same benefits are seen in the cat version of the V-Gel Advanced, with the addition of the fact that they are suitable for all breeds of cats. The original V-Gel required a cuff for those breeds with a high hard palate to reduce the dead space here. In the V-Gel Advanced, this is not necessary and there is no cuff required. Choosing the correct size. The insertion of the V-Gel Advanced is very easy as the patient's anatomy will guide the device into the correct place. This of course can only happen if the correct size device is being used. There are 6 sizes for each device, with a weight guide to each size. This is based on the patient's ideal weight. So firstly, if you have an obese or underweight patient, you must first decide what his ideal weight should be. Once you know this, look on the weight guide, where you will see a lot of the weights are overlapped. Choose the device in the largest size for your ideal weight, as the larger the device, the wider the airway. You can always drop down to the smaller size if you find that this is too big. It's the same when choosing the size for your cat V-Gels. Base it on the patient's ideal weight. Choose the larger device for your weight and have the smaller size available. We have introduced the 0 size for cats weighing from 0.5 kilograms to help with the smaller neutering patients. Preparation of your rabbits for induction. 1 hour before induction, remove all food or any substance the patient may consider to be food, for example bedding or newspaper. Flush the patient's mouth with a syringe and tap water to remove any debris present. This is extremely important as you do not want the V-Gel to become occluded with debris during placement. Select the correct V-Gel size based on your patient's ideal weight. Always have an IV cannula placement to allow for any intravenous drugs to be given at any stage during the procedure. Immediately prior to induction, again visualize, clean and flush your rabbit's mouth to remove any obstruction and anaesthetize your patient to reach an optimal plane of anaesthesia. Pre-oxygenate your patient as the induction drugs are taking effect. For cats, follow your usual protocol with regards to withholding food and pre-medication, but do still place your IV cannula and pre-oxygenate as the induction drugs are taking effect. After induction, apply lidocaine to the larynx according to your usual protocol, ensuring it has been diluted for rabbits. Lubricate your selected device with a sterile water-based lubricant, such as the ones we have shown here. Ensure the length of the device is well lubricated, as well as the bowl. Do take care that the lubricant you are using has not occluded the airway channel. Hold the patient in the same position as you would for ET intubation, ensuring the head and neck are extended upwards. Gently pull the patient's tongue as far forward as possible and place the V-Gel on the patient's tongue with the airway channel facing downwards. Apply very gentle pressure on the device so the bowl splays outwards. Continuing this gentle pressure, advance the device towards the back of the mouth. As you continue, you will feel slight resistance through the paraglottal arch. Continue until the shoulders are pushed up against the paraglottal arch and the tying ridges are in line with the incisors. Once in place, tie the device to your patient and connect to the capnograph or circuit. Confirmation of the placement. Confirmation of the placement is done in much the same way as any other airway device. If using a capnograph, have this connected before placement so that you receive your positive waveforms immediately. Gentle IPPV on the reservoir bag will allow you to visualize the inflating of the lungs. You will also see the regular reservoir bag movements, as you now have a sealed airway. For cats, a piece of thread or cotton wool could also be held in front of the device to confirm exhalation via the V-Gel. This may not work with rabbit V-Gels, as rabbits are notorious breath holders. Therefore, for rabbits, IPPV is the best way to confirm placement of the V-Gel. The angle in which the device leaves the patient should be maintained by supporting the circuit at the same angle. The D-grip circuit holder will assist greatly in this, as not only will it keep your circuit in place, it also supports the weight of the circuit as well. Monitoring the patient is again done in the same way as with the usage of any airway device, by manual observations and recordings, with the use of capnography, by use of a regular or esophageal stethoscope, the use of pulse oximetry. We also advise that a quick and gentle IPPV is performed each time the patient has been moved to confirm the placement of the device. Recovery. Complete your surgery and anaesthetic as you would normally. Allow the patient to breathe fresh oxygen for several minutes and disconnect from the circuit when you are ready. Remove all other equipment and untie the V-gel for quick removal. Continue to monitor the patient for recovery by checking the reflexes. Don't forget, a cough reflex will not be observed. Leave the V-gel in place for as long as possible. Quite often the patients will lift their heads and attempt to remove the device themselves. Gently slide the V-gel out of the patient's mouth past the resistance of the paraglottal arch. Give additional oxygen if required by face mask. It's important to get your patients to eat as soon as possible, and as there will be no discomfort felt, they will be much more likely to eat straight away. Equally, oral medications can be prescribed, as the patient will not be experiencing the same discomforts felt with the use of an ET tube. The use of V-gels without a capnograph. Gold standard anaesthesia will include the use of a capnograph. However, there will be times when this is not possible. If the practice does not have a capnograph, or perhaps they have a static machine that is in theatre and cannot be moved to prep, for example. The V-gels, as with any other airway device, can be used without the use of capnography. In this circumstance, we would recommend other forms of monitoring. Manual observations, use of stethoscopes, use of pulse oximetry. We also recommend that IPPV is performed regularly throughout the procedure to confirm the placement of the device and to ensure the lungs are fully inflated. Blue tongue. The incidence of blue tongue was seen quite regularly with the original V-gel. This is where the V-gel would cause pressure on the patient's tongue and cause the lingual vein to become occluded. With the redesign of the V-gel, blue tongue is rarely seen. If this does occur during your anaesthesia, please first check that all parameters and vitals are good. Do not assume the tongue is blue because of the V-gel. If all your patient's parameters are within normal range, it's most likely that the blue tongue is caused by the tongue not being pulled out far enough when you initially place the device. To rectify this, pull the tongue out as far as you can and give the V-gel a little movement to relieve the pressure. If this does not work, remove the V-gel entirely, pull the tongue out and replace the device. If this still has not addressed the problem, it's more likely that the V-gel is too large for your patient, and you may need to replace it with a smaller size. Laryngospasm. Even though the V-gel does not touch the larynx, laryngospasm can still occur, as this is often as a result of a pain response as well as to stimuli. This occurs quite frequently during anaesthesia, but often remains undetected when using an ET tube, as the larynx spasms against the tubing. A laryngospasm can only occur when the patient is too light. It does not happen when the patient is fully unconscious. If a laryngospasm occurs during your anaesthetic, firstly deepen the anaesthetic immediately. If a V-gel is in place, this can be done with a volatile agent along with the use of IPPV. If a V-gel is not in place, place the V-gel as previously described while simultaneously administering anaesthetic drugs via the IV cannula. Once the V-gel is in place, perform IPPV to deepen the anaesthetic. It's for this reason that the use of lidocaine sprays is still advised, as well as being in line with RCVS guidelines. If you usually use a lidocaine spray as part of your usual anaesthetic protocol, our advice is that you continue to do so. So which device? The V-Gel Advanced is suitable for most procedures you will perform under general anaesthetic. They can be used for those procedures where perhaps a device is not usually placed, for example, the quick cat castrate. They are ideal for radiographic procedures where a lot of positional movement of the patient is needed, but where ET tubes are generally avoided due to the damage they can do. They can also be used for procedures such as bronchoscopy, and the camera is passed through the V-Gel itself. The V-Gel Advanced can be used for dental and oral procedures in both cat and rabbit. We do advise that the device is protected from any drilling and that you continue to pack the back of the throat with oral swabs, if that's your usual procedure. There are some procedures that you cannot use the V-Gel for. These are generally any procedures where access to the stomach via the esophagus is needed, or any procedure where the pharynx is involved. Single use. The V-Gel Advanced is now a single-use device, so the rather detailed cleaning protocol associated with the original V-Gel is now a thing of the past. The V-Gel Advanced will not withstand an autoclave cycle, nor is it designed for soaking in fluids for prolonged periods of time. For more details on this aspect, please contact your regional representative who can discuss this further. For more details on the V-Gel Advanced or airway management in general, please do contact us at Millpledge Veterinary. Alternatively, you can contact Docs Innovant, who are the manufacturers of the V-Gel, or visit their website for further details. Thank you for your time.